Hi, this is Mark Purdue, and you're watching a video on soft tissue and musculoskeletal ultrasound. So we're going to talk about tissue densities and their appearance on ultrasound. Soft tissue, nerves, dense connective tissue, and bone all have distinctive appearances on ultrasound, and that helps us to distinguish normal anatomy from abnormal anatomy. Some clinical applications of soft tissue ultrasound include cellulitis, distinguishing cellulitis from abscess, necrotizing fasciitis, and cutaneous foreign bodies. So by way of review, we need to remind ourselves that certain tissue densities give off certain types of ultrasound appearances, such that at the top on the right we can see this hyperechoic or bright white appearance is going to be suggested when we are insenating structures that are very dense or inflexible. So things like bone or dense connective tissue are going to be hyperechoic or bright white. On the other hand, if we have a fresh fluid-filled structure, a cyst or a blood vessel or whatever, that is going to appear black or anechoic, meaning without transmission of echo back to the probe. And that's because ultrasound waves are extremely well transmitted through fluid media. Consequently, on the other side of fluid-filled structures, we frequently see this kind of posterior enhancement because of the superabundance of transmission of ultrasound waves. Now, if we come back to the middle here, we can see isoechoic. And isoechoic is kind of a combination of brightness and darkness, which is very gray and kind of right in the middle of those two extremes. Structures that are reference points for isoechoic tissues are going to be things like the liver and the thyroid. So that we can see over here we have an anechoic structure that looks like a pleural effusion. Here we have what looks like the liver or hepatized lung. And then over here we're going to see vertebral bones giving off that hyperechoic. Now, the skin, too, also has a distinctive appearance when insenated using a linear probe. Here on the left, we can see the epidermis and dermis combine to provide this narrow band of hypoechoic imagery. And then beneath that, we see the superficial layer of subcutaneous tissue, which is generally going to be fat or adipose. And then deep to that, we're going to get down, as our graphics suggest over here, into the deep fascia and then the muscle and lymphatics. In this cross-section here, you can see that the muscle fibers are showing up as these short axis cuts through the fibrillations here. We can see fascia as suggested by this hyperechoic line, but importantly, we do not see any acoustic shadowing up underneath the fascia. Instead, we see more muscle, and then here we see deep the periosteum, which is going to be the cortex of the bone. On skeletal muscle and ultrasound, we're going to see in the short axis again, we're going to see this hypoechoic, and this is a short axis through the muscle fibers themselves. Interspersed here, we're going to see fascia, and that fascia is that dense connective tissue which is encasing and wrapping around muscles and providing separation. And then if we get down to the cortex of the bone itself, this would be a short axis cut through the bone. You can see that there's not much we can see deep to the bone because of that acoustic shadowing. Now, if we take our beam and we insenate the structure parallel to the long axis of the muscle, we can actually appreciate the linear fibrillar striae of the muscle. Here we've got another fascial plane here and then more muscle. So trying to match up your appearance of the ultrasound with the expected image is how we're going to start determining normal anatomy with ultrasound. Again, we have here the short axis through the muscle fibers, the fascia, and then we get more muscle and then cortex, which inhibits the visualization of anything deep to that muscle. And then just to make one last highlight of the acoustic shadowing, here we have muscle, fascia, muscle, and then the cortex of the bone with a very good example of the acoustic shadowing. Now, tendons are readily seen with ultrasound. If you put the probe on the tendon, you're going to be able to see these linear fibrillations, but because they're more dense, they're going to be a little bit more prominent than muscle. And so you can see these tendons here, but also you can observe them through the range of motion using one of the techniques that we mentioned previously. You can see those fibrillations moving back and forth as the muscular tendinous unit is moved. So lastly here, we're going to look at the main thing we want to see here is this structure right here. That is the median nerve. So this is a short axis view through the wrist. We have the scaphoid and the pisiform, and here we have what looks like the ulnar artery because it's nice and round and anechoic. But the structure that we're interested in is the median nerve right here. It has been described as having a honeycombed or speckled appearance, and that's because of all of the nerve fascicles wrapped up with the epineurium right around here. And the reason that the median nerve is important is that if you're working in orthopedics and sports medicine, you can use ultrasound to identify the median nerve and then inject steroid right around the encasement of that nerve, and that can improve symptoms in carpal tunnel syndrome and median neuropathy. So these are the techniques for doing soft tissue ultrasound. We're going to use a linear probe, and this generates high frequency, which is going to give us nice detail for small structures like the median nerve. Now we're going to use a depth of something like 1 to 5 centimeters. Usually if you need more than 5 centimeters, you're in a deep tissue of the trunk or the buttock or whatever. And this depth is going to be set for you if you use the soft tissue and musculoskeletal presets. Now, just with any other ultrasound, we have to have some gel to transmit the ray from the probe through the patient's skin. But because we sometimes will be using irregular surfaces, like the short axis through the carpals or whatever, or the metacarpals, that ridginess of the dorsum of the hand is going to offset the interface so that the probe does not get down into the groove between two metacarpals. Consequently, we're going to have to provide some smoothing out of that surface, but it needs to be fluid filled. So we'll use a bag of saline, put some gel on top of that, and this provides a very good image, and it's clean and easy to do. If you don't have a little bag of saline, you can simply put the patient's hand in 6 inches of warm water, put the probe in there, and that also will provide a good interface for your musculoskeletal scans. Now, the first condition we're going to talk about is cellulitis. If you look at the graphic on the left, this includes not only the epidermis and dermis, but all the way down into the subcutaneous fat. This cellulite, hence cellulitis, is an inflammation of these layers of tissue as a result of infection. Typically, this is going to be something like a streptococcal or staphylococcal species, and these conditions generally will respond to antibiotic therapy. The symptoms of this and the signs, as you can see here, we've got erythema, this kind of intense, fairly well demarcated erythema, and you can see that the pen has drawn a line here. They're going to be tender to touch, usually edematous, warm to touch. They occasionally will have a fever, but it's not necessary. And so when we see cellulitis, treatment with antibiotics is a fairly straightforward procedure. Sometimes cellulitis is not what you think it is. Sometimes it's a more serious condition. So we can pop the ultrasound probe, and if I can direct your attention to the right, what we're going to see here is the normal scan. And in the normal scan, we see the dermis and epidermis creating this thin band of hypoechoic appearance here, and then even more hypoechoic or anechoic here. If we turn the gain up, we could see a little bit more. And then now again in the normal picture, we have this fascial plane, then deep fascial muscle, and so on. In a patient with cellulitis, this subcutaneous fat is inflamed from infection. There's a lot of vasodilation, and so there is an engorgement of plasma into these little lobules of fat, and it creates this kind of pebbly or cobblestone appearance of the subcutaneous fat, which we can see again here with the highlights kind of showing you what that's all about. So this is interesting, but is it useful? Well, if we think that the patient has cellulitis and then we ultrasound the patient and we see this cobblestoning, it does not change our plan. We will still give them the appropriate antibiotics. What ultrasound does help us do is to distinguish cellulitis from other conditions, particularly abscess. Consider here we have an abscess on the left and a cellulitis on the right. We could easily swap these images and we still wouldn't know which is which. Sometimes patients come in and they have a classic abscess. They frequently do. So they've got a focal area of redness, swelling, tenderness to palpation, and when you put your gloves on and press on the center of that abscess, it exhibits fluctuance, which is the feeling of squishiness associated with fluid-filled structures. But sometimes abscesses are deeper into the tissues and you cannot appreciate that fluctuance. So it begs the question, cellulitis or abscess? Well, if it's on your arm, I might say something like, well, let's just numb it up and stab it with a scalpel and see if any pus comes out. And that would be fine, and that's done frequently. However, if it's my arm, I'm going to say something like, well, why don't we put an ultrasound probe on there and see if there is an abscess? And here's what we would see in a case of an abscess. We have this fairly well-defined wall here, and then we have anechoic areas here, and then hypoechoic areas here. And this represents purulent material, or pus, as we say, and then this hypoechoic area is going to be flocculent material, and that's going to be dead white blood cells, tissue that is dying as a result of the bacterial toxin, and all of this is going to kind of mix into this abscess, creating this mixed picture. Here we see a thinner formed abscess, but you can see over here, after the abscess has been there a while, if there's a lot of breakdown from the bacterial toxin, you're going to have all of this tissue remnants and debris products, and then it looks even thicker over here. Nevertheless, they are all abscesses. Now, if you have a patient come in and they complain of pain and redness and tenderness and warmth to touch, and let's say it's in like the groin, and you put the ultrasound probe on here and you see, well, this may be an abscess. It's got a very well-defined border over here. It has anechoic areas and then a hypoechoic area. I think that's an abscess, and I'm going to incise and drain that. You would be wrong to do that because this, in fact, is a lymph node. And so lymph nodes, here's a better example to the upper right, have a very well-defined border because of their cortex covering. They also have what looks like a medullary structure, such that lymph nodes kind of look like baby kidneys stacked throughout the body. You know, a patient can have lymphadenopathy associated with a cellulitis, but not an abscess. So if you see this, ask yourself, is it the size of a lymph node? Does it have tissue organization of a lymph node? And is it in an anatomical place throughout the body that would be consistent with lymphadenopathy? And if the answer to those questions is yes, you should not incise and drain that structure. Now, here we have cutaneous findings that we can see. We have erythema. We have little areas of blister formation, and then we have a larger blister-like structure, which is going to be a bulla, and this bulla has been ruptured. Over here we can see kind of petechial-type lesions. If we pressed on them and they didn't go away, we would say they are petechial. And so we're asking ourselves, well, could this be cellulitis? Well, the answer to that question is it is not. It is, in fact, necrotizing fasciitis. And if we look at a more typical presentation over here, we can see that this patient's leg is deeply engorged with edema. It almost has this kind of woody appearance. Over here, you can see this kind of peau d'orange or skin of the orange type appearance from a lymphatic engorgement. Here we have these hemorrhagic bullae and then bullae that have ruptured over here. These patients with necrotizing fasciitis can die from this. These are surgical emergencies. And so if a patient comes in with a presentation like this, it may be hard to distinguish cellulitis from neck fasc. The problem with that is that if you had your milder presentation and you don't identify that, then that patient can go on to die because of the bacterial toxins associated with this. Neck fasc is a surgical emergency. As with abscesses, to cut is to cure. And so these patients have to undergo rapid emergent debridement, and this is usually a very radical procedure, as you can see from these images. And then within 24 to 36 hours, they continue to undergo these radical debridements until there is evidence of no dying tissue left. Well, how does this look on ultrasound? Well, before we get to that, remind yourself that sometimes something looks like cellulitis. Well, what would be the clues to consider neck fasc? And that's going to be rapid development. This morning it was not so bad, but this afternoon it's terrible. Significant pain. A systemically sick patient in terms of fever and lethargy, decreased energy, all of those things. If you've got a patient also that's immune compromised, diabetes or whatever, you need to consider neck fasc. So the ultrasound on the left, what we're seeing over here, you just place a probe on them. with a sterile cover to keep your probe clean. You're going to insunnate down here using soft tissue technique, and what you're going to find is this intense hyperechoic fascia, and it's inflamed, as fasciitis suggests. And then also, as a result of the necrotic effects on this fascia, you're going to see what we call this dirty gas shadowing. This gas does not belong in the subcutaneous space. So in the setting of infection, if you see this that looks like dirty gas, and you have to consider that there is either a gas-forming organism or neck fash. And over here you can see, even on plain film, if that's all you have and you suspect neck fash, then you need to x-ray that patient, or if it's rapidly evolving, then disposition that patient strictly on clinical criteria. So the last thing we're going to talk about here on the left is that we have a patient who complained of increased swelling, redness, tenderness, and decreased range of motion after poking himself with a stick, something like a toothpick, and he complains of foreign body sensation. And so appropriately, the clinician takes a soft tissue x-ray and they see nothing. And the problem with that is that wood does not show up well on conventional x-ray. So another clinician popped the ultrasound probe and see this very well-defined linear foreign body, and they could isolate the location of that, numb it up, or digital block the patient, and then remove that. Now you may be asking yourself, what's the big deal with a woody foreign body in the finger? Well, a couple of things. One, if you have an immune competent patient, it will take thousands and thousands of bacteria to inoculate that site on the finger and to generate an infection. However, if you have a patient also immune competent and you stick that wooden foreign body into the subcutaneous tissues, it will take only a dozen or so bacteria, just a dozen bacteria, to generate infection, because the presence of a foreign body impairs the local immune response to those bacteria. So foreign bodies are going to lead to an untreatable infection. This marks the end of soft tissue and musculoskeletal ultrasound.